I always feel really privileged to be invited, and I would like to thank Ellie and the trustees and the organising committee for inviting me back to this conference, because it is a conference very much for practitioners and all about patients, isn't it? And every single one of us in this room is all about changing practice for the benefit and for the betterment of our patients. I feel I've got the best job in the world. I'm sure you do, don't you? That was a resounding yes, okay. I'm really lucky and privileged because I work in a specialty I really care about. I learn a lot every single day from every one of us. Just a few quick stats. I've been in the NHS 43 years. I've been in the tissue viability since 78, so that's 29 years. And I've been a nurse consultant for 25 years. But it changes every day, and that's the beauty of it. We can never stop learning, can we? And we learn most from our patients. So who are the most important people in this room? The audience, the speakers, the chair, or the audience? Anybody who says the speakers or the chair can leave now. Because, of course, the reality is you've got a wealth of experience, haven't you? You've got a wealth of knowledge, and as has been advocated all through this morning, it's all about sharing that to ensure that we are evidence-based practitioners. Now, just to pick up on a couple of themes that I've mentioned, and I make no apologies for the fact that some of the things that we talked about this morning will appear in this session as well, because we've got to put what is the optimum treatment choice for patients with leg ulcers into context, haven't we? And anybody not know what the optimum treatment choice for patients with leg ulcers is? That's good, so I can go. So we will unashamedly put it into context, but just to say it is important that we obviously know what our healing rates are in the complex wound clinic that we run, where we see a lot of people with leg ulcers, as well as a whole range of etiologies. Our improvement rate currently is running at 92%. Our healing rates are about 55%. We've discharged quite a lot of people recently. But that changes, and it's variable. We're very privileged and lucky because when I started in the United Lincolnshire Hospitals, there was just me. I now have a team of 7. It's a very multidisciplinary team approach, and everybody is important, aren't they? Please forgive me if there's any doctors, but doctors are really important as well. We need to work with them. It's not against, but equally they need to support what we're doing. Some of my biggest challenges are when we get patients on a care pathway and discharge them, that it's not always followed. For a whole variety of reasons. That's not to say why. And unfortunately, in my experience, the CCGs have made it more difficult from a financial perspective. Not because people don't want to do it, but because resources appear to be a little bit more limited. And I think it's fair to say that leg ulcers were always seen as the Cinderella of wound management, weren't they? The Cinderella sort of, people have a leg ulcer, we tried, if it doesn't heal, well, it's not a problem. To us, it might be to them, but well, and there is a realization that there has been a lack of resource availability for managing all wound types, of which leg ulcers are a growing population. So, and this is just to show you how things have occurred relatively quickly over the last couple of decades, how things have tried to change. But even with the research and the evidence, and I do believe, and just picking up on Jackie and Zina's points, randomized controlled trials are really important, aren't they? Evidence is really important. And, yes, we can accept that, well, if that bandage has got exactly the same properties as this bandage, if they've done the research, we don't need to repeat it. I personally, and as any of the companies will know when they come to see me, we sort of say, right, okay, let's compromise. I'm not expecting you to do the RCT, but I do expect you to do some comparative work with that bandage so that you're comparing like with like, and then I can see if there's a different healing rate. I am expecting you to do meta-analysis of multiple case studies. Don't give me a case study as evidence. That's really not beneficial. It's very helpful for practitioners once we put something on the formulary to convince them that that particular product works with their particular patient type. That's a different matter. Case studies are excellent for that, but it's not evidence. So can you see how we need to have that open discussion? And we do need to challenge people who are giving us the evidence to give us the evidence that's meaningful. But we should always ask for and aim for randomized controlled trials where they're possible and practical, because that is the gold standard from an evidence point of view. But accepting that sometimes, somewhere in between is okay, at least to put us forward. Why do I say that? Clinically, recently we've had a real issue, and the patients have had a real issue with patients coming in with compression bandaging. That's great, advocated. We sent them out with a super absorber, but the super absorber we put on was close to the skin. When the patient comes back, the super absorber is on top of the compression bandaging. Somebody said, well, there was a paper quoted in 2011. Yes, there was a single paper. This was when the super absorbers first came out, and we all talked about it as nappy technology, and there was a big amount of swell. So the person who wrote that single paper did want to just check. And yes, there was some indentation, but that would be a clinical decision for you, choosing which super absorber caused less indentation, less trauma, dealt with dealt with the absorbency, yes? To be fair to the companies, there's a lot of change in the technology since 2011. The super absorber we use is microthin. Highly absorbent, doesn't swell very much, but holds large amounts of fluid. When it's on top, what do I see when we take the bandages down? Macerated skin. Large areas of macerated skin. Does that help us move the patient forward? Not at all. When I ask the district nurses why they put it on, evidence says. If you read the paper, it says more research is required. That was a surprise, wasn't it? But they also acknowledged it was a very limited study on 4 patients. I would argue not one of us in this room is an evidence-based practitioner if you change your practice on that one paper. Here endeth the first lesson. So now moving on, as you can see, there's a whole range of things that have happened, and these are the key milestones. I'm not going to go through them with you because A, I'm sure you're aware of them, and B, we haven't got time. But yes, improved healing rates started to occur, particularly with the introduction of a multi-layer bandaging system in '92. I was very privileged to work with Christine for 5 years in her research team. And just as it happens, to take another theme, we did a lot of evidence about the use of dressings under bandages and whether that affected the compression profile. And the answer is no. Minimally, of course, anything you put on will affect it. But you're the clinician. You're assessing, you're making a decision as to whether you need to alter that or vary the compression system to suit the whole overall treatment, yes? So, it's not the dressing that's the problem, it's the way we're using it. It's not the bandage that's the issue, it's the way we're using it. So we need to be involved in that. Quality of life issues were really studied in the leg ulcer world in particular. And of course, remember, please, that health-related quality of life isn't just does it cause you pain at the time of dressing change. There are 5 domains that need to be considered. So you're looking at the physical, the psychological, the emotional, which is the social, the economic, does it affect their ability to work, and the spiritual. There's 5 domains. And again, the companies know me well. I get very worried. I get quite upset with them when they say, we've done a health-related quality of life study with our dressing. And the only question they asked was, did it cause pain at the time of dressing change? So again, we need to know what we're talking about. We need to use the right terminology. We need to be getting the right information. And of course, what is a great advocate or a great change is the development of the leg club model, which has been shown to work, hasn't it? You know that as well as I do. It's a real step forward, and every one of you in this room is a patient advocate, aren't you? That was even quieter than the first question, but you are. Don't devalue that role, but make sure you are evidence-based as well. And you have the opportunity to talk to your patients and get the information you need to make the clinical decisions with the evidence. So what were the missing elements? And still there are some, as we've already alluded to, mainly because of financial pressures. There's still a problem that, although it's accepted that leg ulceration is a significant healthcare problem, the resources aren't there to deal with it. Then we still need lots of positive attitudes that actually can heal a lot of pressure ulcers. People still believe that if you've got a leg ulcer, that's it, you've got it for life. Of course, we need to know what type of leg ulcer, we'll come on to that in a second, but most of them, in fact, the majority of them can be healed with the right treatment. The only thing with the sequins that were developed in the past, though, and the tariffs that were talked about previously, is they were based on the NHS tariffs were based on patients with a simple venous leg ulcer. How many of you have seen a simple venous leg ulcer in the last 10 years? That was the answer I was expecting. Because they don't exist anymore, because patients have changed. We're all getting older, more concomitant conditions, more drug therapy. Take an aspirin for your heart, that's great, but it will have a downside on your healing process. It will have a downside on your risk status. I preferred my father's philosophy when he was alive with preventing heart disease and a glass of red wine every night. I don't drink red wine, by the way, but I like the idea of the wine. So there's a whole range of things, aren't there? And as I say, the clinical research is the key. We do need to strive for that because it is all about evidence-based healthcare. And you heard a definition of that earlier. So yes, you're really surprised that I said the gold standard of management then is compression therapy. There is no doubt about that. The evidence is clear. It is there in the literature. Yes, there is some debate, and as Sina was very rightly pointing out, it's not that it doesn't prove it, it doesn't disprove it. So, you know, when you read that, look at the actual wording that they're using. Compression therapy, it's generally agreed, should be the first-line treatment for all patients with venous leg ulcers and should be initiated as soon as possible. That's why you've got a sequence of getting the patient to, in the community with the right diagnosis or to a specialist in 2 weeks. Because I know in Lincolnshire, there are lots of patients who are unknown to the community. We're a rural area. Patient might have been dealing with their leg ulcer for 10 years on their own because they either, you know, were very stoical, didn't have the support network, you know, didn't want to bother the GP because we're all very busy people, unknown to healthcare. So, of course, it's going to take us longer to have a positive effect on that patient than it would if we'd seen them at 3 weeks or 2 weeks or as soon as the injury occurred. And of course, the aim should be to try and use full compression when the arterial supply is good to prevent delays in healing. So, without preaching to the converted, which I know you are, of course, we need our assessment framework to be holistic, systematic, and evidence-based. But evidence-based doesn't have to be everything is a RCT for the reasons we've talked, but it should be the highest level of evidence that's available to us and that we've asked for. Models for holistic assessment, there's lots of them out there. You're not expected to look at these particularly, but you can find a holistic model for almost any disease process. And so we need to be aware of the one that's relevant, most relevant to the client group that we're looking at. Why? Because we're dealing with the whole in the patient, not just a part, or as we ever all like to say in tissue viability, not just the whole in the patient, it's the whole of the patient. And that's becoming even more important with the aging demographics or the changing demographics. Why? Because, of course, you know, people do need to be partners in our care. We're very keen to ensure that we involve the patients in all decision-making process. We tell them all the results and what they mean of any investigations we have, as I'm sure you do. We're lucky in the complex wound clinic that we run that we have half an hour to 3/4 of an hour slots. So we can build up a rapport with the patient. They're not in and out. They're not just another number. I feel very sorry for GPs who are given 10 minutes. How can you make an holistic assessment in 10 minutes? It's not practical. It's unfair. So, and obviously, you know, if we can get the patient on board, it's their decision. They want the therapy. it's obvious that it will be better tolerated, and they will give you better feedback, won't they? Because they'll tell you if it hurts or there's some issue with it much more quickly. So the elements of assessment should, of course, acknowledge a recognition of the etiology in the patient and the patient ulceration, holistic patient and wound assessment, which of course recognises any family history which you will have built up over time, identification of specific symptomatology, because that's where it's really important that we combine the right dressing for the right wound, for the right symptomatology at the right time, which may need to go under, dare I say it, compression therapy. It's how you combine the two. That's the clinical decision you make. Assessment of patients surrounding general skin health, that's really important, isn't it? Health-related quality of life considerations, and as we've pointed out, all domains, not selected highlights. Recent vascular involvement and assessment, we need to know what they are, and we should be wary about putting compression on unless you know what the vascular status is underneath. The guest paper that was being talked about earlier showed that only 16% of patients in the UK who have compression therapy on have had a Doppler. That to me worries me. We will not put compression on unless there is a recent Doppler reading. I get involved in writing nice guidelines, please don't blame me. But if they have a tissue viability, I'm usually involved in some capacity. And I'm very proud of that. And I'm really delighted to be involved in that process. I do get frustrated when people say the guideline doesn't tell me anything. There's no research. Well, I say get involved and provide the research. Do something about it. You can't change anything unless you're involved in actioning it. So please do get involved, but you need that vascular assessment. Now, the original NICE guidelines, RCN guidelines in 2002, said that everybody should have a Doppler every 3 months, and that was based on good evidence at the time. It was withdrawn, and it's never been replaced because it got to be unrealistic because of the changing demographics, etc., etc. Doesn't mean it's not still the ideal, it is the ideal. But living in the real world and accepting the clinical pressures and changes, general consensus would now agree that you should have a Doppler within the last 6 months if the patient has active therapy. If there's maintenance and prophylactic, then yearly is fine, no problem with that at all. But 6 months, anything over that, and particularly with the changing population, the arterial system can change a lot in 7 months, can't it? 8 months. And even though my wife's a radiographer, I do not have X-ray eyes. I don't know what's going underneath the skin. So we need to have that support. And so timely Doppler assessment and results are good. Because of course, I know if we'd had more time, you all could have drawn this diagram for me. You know the circulation well. That's what's damaged, that's what we're looking at. Don't worry, you won't get a multi-choice paper on your way out. But we do need to know of both, the pathways, as was beautifully pointed out in the earlier assessment session, about where the veins and the arteries are, what the difference between them are. Just basic, it's fundamental physiology, but it's actually very important that we remind ourselves of the importance of it. I do get horrified at the number of people I teach at the university, students who don't know their A&P. The moment they qualify, they don't know it. And so they start to learn when they get in the clinical setting as a staff nurse. I think that's a bit late, but anyway, we're trying to address that problem, as I'm sure you are. We need to know what the veins do, and of course why we are getting a lot more. You don't get simple venous leg ulcers anymore. They're now mixed ulcers that will move on to become arterial ulcers if we don't do something about it. We know what the problem is, and as has been already pointed out, there's lots of stats and figures. Venous leg ulcers are defined as open lesions between the knee and ankle that occur in the presence of venous disease and take more than 2 weeks to heal. And that was the NICE guideline 2003 that was talked about earlier. 1.5 of the UK population have leg ulceration. And the recurrence of ulceration, 12-month rates are estimated at between 18 and 28%. And that's another clue about evidence and results, isn't it? Because actually, in one sense, if we do all the right things and we heal the wound, that's great. As I said, we have 55% healing rates. What's actually more important, that's good, I hope, but actually what's more important is how many of that 55% don't come back to us. That's how I measure what we've actually done for them. It's the recurrence rates that are actually the most key. The epidemiology we've talked about. We know there's lots of associated patient factors. We haven't got time to go into this, but we do need to take account of them and we need to address them. How many people come in to your clinical setting, they certainly do to mine, with a cardiac condition? They've got raised blood pressure. They had compression on because they had a venous leg ulcer before admission. We take it off on admission because they're acutely ill, the leg is up, the venous return is being aided by gravity. In the acute stage, the cardiologist says, can you put compression on? I say no, because you're dealing with lots of drugs. You're trying to not overload the heart. We put compression on, what's it going to do to the circulation? Cause a problem. So you have to look at it as a whole, not in isolation. And that's just one example. Chronic venous hypertension, I'm sure you're very well aware of this, and it is because of the valve deterioration or calf muscle pumping. You know what the classification of venous insufficiency is. Again, we just need to be secure with it. Do we need to all remember it? Of course we don't, but we need to have it in our pocket as a memory jogger or somewhere in the practice, somewhere in the clinic that we're running, so we can refer to it. Nice guidelines aren't for you to carry around, they are to refer to when it's relevant and to keep you updated, as any other guidelines are. And this is a very good example of one that was healed, the good old lipodermatosclerosis as evident, but all went well. We need to do the Doppler. What is it? It's simply the ankle systolic pressure divided by the brachial systolic pressure, but it's classified by Doppler. You've heard about the pulses that you should be assessing, remembering that some people don't have the dorsalis pedis, so don't panic them if you say, I can't feel it, just look for somewhere else nearby, such as the anterior tibial, because of course, again, we know the pulses are going to be on the arterial system and we need to have a good understanding of it. What is the interpretation? There are lots of cue cards like this, so I'm not going to spend time on it. But the big important bit is we need to know what that Doppler is before we choose and put the compression on. That is a key statement, I would argue. We can't guess at it. And of course, if patients are coming back to a specialist unit or you're seeing them every week, then you can possibly work with lower levels, sort of 0.5 to 0.8, with that clear supervision pathway and on constant feedback. Generally speaking, it's 0.8 and above, then yes, that's the sort of benchmark for normal compression therapy. There are lots of differential diagnoses, so as I say, we do need to confirm, and the symptomatology has been identified. So the optimum treatment choice is compression therapy. Cochrane Review provided the most complete overview of the RCTs, the randomized controlled trials in venous leg ulcers up to date, that stated that compression increases ulcer healing rates compared with no compression. Now that must be a positive. I'm sure you'd agree. So it is better to put it on than leave it off. And that confirmed data reported in a number of previous studies, not least from Moffitt et al. How can we apply compression? And this is where we do need to be very much involve our patient, isn't it? Because there are various ways that we can get it. From a prophylactic point of view, it may well be that you use hosiery kits early on before they get to be, because you're aware of the venous disease. Or when they've had successful compression therapy and they've healed, you're going to advocate the use of hosiery for the rest of their life, aren't you, to stop recurrence rates? So we need to introduce and talk about the subject very early, and it does help the patient to facilitate self-care. Of course, there are issues about application if the patient has rheumatoid arthritis, and that's where, knowing your patient, you can identify and tailor the treatment choice to them. Compression wraps, we use a lot of these, and this is something that's made a massive difference to us in the community because the patient feels in control. We do occasionally, and I apologise because I know there's a GP in the audience, so we have to have a lot of conversations with our local GPs to get them to prescribe it. But once they do prescribe it, they see the benefits of it because it keeps that patient out of their surgery. They're just seeing us in the clinic. And there's a whole range of these. It's not for me to promote any particular type. It's the therapy that we're interested in, and it's the compression wraps give you high compression, but the patient feels in control. And then, of course, compression bandages. The most evidence is for the multi-layer system, but there's a whole variety of bandage types, aren't there? And now it's incumbent on us to know what the properties of the bandages are that we're using. Not just it's the same as one we've used before. Does it give us, is it a short stretch or a long stretch? Does it give us high levels or low levels of stiffness? Does it help promote healing by doing X and Y? So it's really important. What's the application technique? Is there a different application technique for the different bandages? We know there is, but we need to be aware of that. We have 3 bandage systems on our formulary. We have a short stretch version, a multi-layer version, and we have a combination, a one in the middle, that's said to promote the properties of a multi-layer system, but in 2 layers. They're the 3 that we have. You may guess which one that is now. We helped develop it, so it's there. But it's a very useful, and it gives us a mix and match scenario. So we don't just say, oh, well, everybody goes in this type. It's by assessment, discussion with the patient, what's right for them. So the selection of compression devices is obviously going to depend on a lot of things. We've already alluded to them, and compression therapy can be applied by means of lots of different devices. We've already said elastic or inelastic, short stretch, long stretch, elastic stockings, or the elastic kits, as well as the adjustable compression wraps. But remember, there is a need and a role for intermittent pneumatic pumps. Particularly in any setting. There's nothing to say it can only be done in the acute setting. It can be done in the community setting at a patient's home to complement and actually increase the value of the compression therapy. So which kind of compression therapy should be used in BL for the treatment of venous leg ulcers? It's still being debated. Who can inform that debate? You can, by doing research, feeding back, getting involved in the process. Multi-component bandages, which involve both short and long stretch, and have been shown to be much more effective than single component bandages in achieving ulcer healing. There's lots of evidence for that, due to the ability to maintain pressure and stiffness over time. So if you're happy that the leg ulcer and the symptomatology can be controlled for up to 7 days, for argument's sake, with the treatment choice that you've chosen, then that's the layer system that might be right for you. But if this chap has got that ulceration due to previous trauma, but it is a venous ulcer, and he wants to work, he might not be able to want to put 4 layers on, might he? Because he wants to still put his shoe on and get to work. So that's where you would vary, have a different system. They've been shown to be cost-effective as well as clinically effective, and there is plenty of evidence to say they reduce healing times. Compression bandaging in situ, you don't need to see that. Inelastic or short stretch materials and multi-component bandages do not give way to the expanding muscle, so they give a lot higher resting pressures and working pressures because the calf muscle pump reflects against them. And such bandages have been shown to be both comfortable and are more effective in improving venous hemodynamics, particularly in the standing position and during muscle exercise, I'd say, because of this reflection of the calf muscle pump. Educational support is required for staff as well as the patients, isn't it? How many of you can put your hand on your heart and say everybody you know that's put compression on has been fully trained? We have a rule in the acute trust where we won't let anybody put compression on unless they've done a recognised university course. I know in the community there's a lot of people do competency-based training, and that is fine as long as you're able to reassess the patient, reassess that person every 3 months to check they're still competent. Have practical difficulties. I get worried when people say, well, we let people put it because they went on a two-day demonstration by a particular company. They know that bandage technique well, so they can put all the other bandages on. No, they can't. Really dangerous. There's a big debate about should healthcare support workers put compression bandage on. I'm not going to get into that today. You may, surprisingly, that's for another debate. But, you know, it is important that if we are asking people to do something, they are suitably qualified. And whoever they're working for is happy and is happy to take account. They've got individual accountability, but is happy to take responsibility for what happens. So GPs need to fund practice nurses to do relevant courses, don't they? Not just ask them to add it to the list of things that they should be doing. And, you know, but to be fair, the GP's got to get something back for that. So, you know, you want that person to still be around and develop a specialist clinic that will demonstrate healing rates. So, important that we are trained, important that we are deemed to be competent. Could be argued this principle should apply to all compression systems, as we've just, I think, alluded to. Compression wraps, self-adjustable compression devices may not be as stiff as short stretch bandages, but may represent an effective alternative. There's very little evidence in the published world because they are relatively new, kids on the block, that new dressing that was being talked about, just wanting to launch it. But you can help develop the evidence, can't you? So work with the companies. They're not enemies, that we're all working together for the same aim, to achieve better outcomes. And as we've already said, they do, and I say may here, but the reality is in my clinical experience, they do aid self-management. And the role of compression hosiery in the most recent meta-analysis comparing the effectiveness of elastic stockings and inelastic bandages in promoting VLU, it was claimed that the superiority of stockings can mainly be explained by the fact that in most analysed papers, good stockings have been compared with poor bandages, which is unfortunate. But again, that's down to us to read the literature and make sure that we're comparing like with like. You know, we can't say, you know, and that's why when we talk about pressure ulcers, for example, in my own trust, we developed a robust tool for, I can tell you the incidence of pressure ulcers in my trust on a daily basis. I can tell you the grade of any patient who has a pressure ulcer on a daily basis. The ward have the feedback mechanism. They have a table and a graph. But I say to them, don't compare your ward with any other ward. That's not what it's about. Because I would expect the incidence of pressure ulcers in a maternity unit to be a lot lower than on an orthopedic unit. You can only compare yourself with your own best data, can't you? So, and it's exactly the same with healing rates. So yes, be aware of the national averages, but compare it with yourself. Intermittent pneumatic compression. Again, there's no comparative studies, which would be the next best thing, rather than RCTs, but it has been shown to sustain compression and that then promotes healing again. And when compared with no compression, IPC is shown to increase the VLU healing rate. I think we're just acknowledging that compression is the key here, and how we get it may differ depending on our clinical situation. So there are clinical practice guidance out there. Some of the statements that we need to take account of is that compression therapy is recommended over no compression. I think we would all agree with that in patients with VLU to promote healing. In patients with VLU, stronger compression over low compression has been recommended, and it has been shown to increase healing. And there's various papers being produced where you know, talks of 60 to 80 should become the norm instead of the 40. That's still open for debate. There's still a discussion, and we should have that discussion. Really important. that we debate and understand why that is being said. But of course, whatever we do, as I say, when I take the bandages down and the super absorbers on top, I need to monitor the outcome, don't I? I have to say, in 100% of cases, the patient has had massive maceration of the skin. So even though this one paper suggested something, I'm not going to follow it, because the clinical evidence is telling me something totally different. And so we need to be aware of that. We need to utilize everything, the evidence of our own eyes, the clinical evidence, the published evidence, and the evidence of our colleagues in discussions and reflective practice. So best practice suggests, therefore, that all venous leg ulcers should be measured at a minimum of 4 weekly intervals. And of course, you should be very aware of your local policies on how you are measuring and recording leg ulcer progress, so that next year when we come back, you'll be able to tell me what your healing rates are, won't you? And you'll be able to tell me what your recurrence rates are, which will be great. So, why things do go wrong? This is clear evidence of a compression therapy being applied incorrectly by the wrong person. I unfortunately have to say this was a person who had had compression therapy put on in the community by a healthcare support worker. I say no more. It's not that she was necessarily wrong, it was maybe that she was never supported, never taught, I don't know. I just see the evidence of it when she came in. So we need to be very aware. We reviewed a whole range of guidelines. I was part of the author team that developed the UMA guidelines on venous leg ulcers in association with our Australian partners, who I'm pleased to see a couple of them here today. We have looked at a whole range of guidance. Do you need to know every guidance? No, you don't. Do you need to know the principles underpinning them? Yes, you do, because it affects your clinical judgment every day. So there's a lot of useful reading out there. There's lots of local, very easy dip in literature. The best practice statements are excellent. The optimizing venous leg ulcer services are consensus documents that are very clearly evident to you. Obviously, I'm going to promote the UMA guidelines because they are worldwide, joint, say with our Australian partners. All the principles, all the evidence that I've talked about you can find in there, very easy, and these are very accessible on the website. But mostly, and most important, I'm going to rely on you to do what's best for your patients. Thanks very much for your time.